Good afternoon, everyone, and thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin our session. To help us with attendance and to introduce yourself to the group, please enter your full name, affiliation, and email into the chat. Please do remember to stay muted unless you are speaking. We encourage using the chat and or the raise your hand feature to pose questions and share perspectives as well as resources throughout the session today. And if you are having any connection issues, please privately chat our wonderful Echo IT Karen for further assistance. As a note, these sessions are being recorded and they will be shared on our website after the session. Therefore, no personal health information will be allowed at any point, and this includes things such as names, addresses, birth dates, appointment dates, or any other identifiable information. And for reference, the slides for this presentation, this session will be shared as well on iEcho, our platform, so you can refer to them after the session as well. At the end of the session, the Echo team will be sending out a post-session survey link. We kindly ask that you all complete it as it does provide us feedback on how to refine these sessions to better address your priorities and your interests. And finally, Echo is an all-teach, all-learn environment, so we do encourage everyone to participate in the conversation and to raise questions. Let's always make every effort to continue having the space that is respectful and safe for everyone to learn. And so with that, we'll go ahead and move on to some introductions. I will begin with Dr. Walker.
Hi, good afternoon, everybody. Crystal Walker, doctorally trained PA, and I am the Director of the Clinical and Medical Services for My Health, My Resources of Tarrant County Substance Use Department. Welcome.
Thank you, Dr. Walker. Dr. Kowalczyk.
Hi, Alicia, Dr. Kowalczyk. I'm with Baylor Family and Community Medicine in Santa Maria Hospital, boarded in addiction and family medicine.
Thanks, Dr. Kowalczyk. And playing a dual role today as our lead specialist and our didactic presenter, actually triple role and a hub member, Dr. Weems.
Hey, all, John Weems here, internal medicine doc and addiction specialist here at CommUnityCare FQHC in Austin and UT Del Med. Excited to try to play a triple role today, see how it goes. And a great case too, excited for the case to come. I think it fits really well.
Thanks, Dr. Weems. And finally, our case presenter for today, Maddie Escamilla.
Hi, everyone. I'm Maddie. I'm a physician assistant at JPS Hospital in Fort Worth in the Psychiatry Consult Liaison Service, and I will be presenting our case today.
Thank you, Maddie. We're so grateful you're here to present this case. And thank you all. I do see a lot of introductions coming in the chat, so please do keep that coming so we know where you're joining from. And we will go ahead and move on to our didactic presentation for today. So Dr. Weems, you may take it away.
Sounds great. Let me share this. All right. Does that look all right, Angela or other folks?
That looks good. Now it's in presentation mode.
Okay, lovely. All right, y'all. So thanks everybody for being here. Today we're going to talk about some novel contaminants. So these are emerging drugs that are likely to affect the patients we serve, with a focus on those which have been demonstrated to be on the rise nationally and those that are particularly prominent here in the state of Texas. I don't have disclosures. And then the learning objectives today, first are to describe the clinical features of intoxication withdrawal syndromes that are associated with non-prescribed benzos and other sedatives. Secondly, to identify emerging sedatives, including novel benzos, high-potency synthetic opioids, and alpha-2 agonists that are in the Texas drug supply. And then finally, to apply clinical strategies like harm reduction and withdrawal management for patients exposed to these contaminated substances. All right, so thinking about learning objectives when it comes to emerging drugs, we kind of miss out on some really important things like the social context of substance use, how patients are using substances. And I think Maddie's case really brings this out. And instead, we kind of really narrow the focus, sometimes somewhat reductively, on the substances themselves. And even if we have this kind of broader view, we still miss out on what's so rich about clinical practice, which is everything that makes this human being who they are, and their story and what they show up with. So just before getting into a really focused talk on the chemicals and how to manage the clinical syndromes they bring, I just wanted to call out that our patients are so much more than that. And this piece of knowledge about the chemicals can hopefully help serve the individual patient and not lose sight of everything else that they bring to the table. I also wanted to start with resources. So the first two on the left there, the first is the CSTAT harm reduction echo, which is still available on YouTube and hosted by BeWell, and is just a treasure trove of knowledge about things like this. Claire Zagorski is a national expert and gave a great talk in January, and that's a QR code to her talk. Some of the highlights there are really pointing out how the ways we know about new emerging substances in the drug supply, it's mostly post-mortem or drug seizure data. And there's other ways to think about this, particularly community drug checking and learning from people who use drugs. It was some of the takeaways I had from that great talk. And then secondly, below, Dr. King from Wayne State gave a recent talk in PCSS from a toxicology perspective, which is just a great talk. If you want to learn more, this will be drawing from wisdom from both of those, and they're more extensive looks if this draws your interest. And then finally, and this is from Dr. King's talk, that there are so many different ways that to know about these, and I think in clinical practice it's tough to keep track. I rely on folks like Claire, and then talks like PCSS, but there are also a lot of other resources that you can see there. All right, and with that background, let's hop into a case. So this case starts with a 29-year-old with opioid use disorder who's brought to the ER by EMS. And they were noted to have partial responses to intranasal naloxone, which was delivered 4 times in the field. I hope this is a kind of familiar story a familiar case to people. And I hope too that one of the first things that comes to your mind is that there are no naloxone resistant opioid overdoses. So something else is going on. And when you start to think what else could be going on, I think that's a good time to bring up a differential built with contaminants. And so an analogy that I hope is helpful to think of this is, imagine going to a local safe supply shop, like a bar, and you're going to get the mind-altering substance that you wish. And so in this instance, let's say I show up and I'm going to get a dad beer, so like an IPA of some kind, and I order 3 IPAs. And the first one is truly that it has the quality-controlled anticipated amount of the mind-altering substance of the ethanol. The second one is an NA beer, so it's nearly the same taste, but does not have the amount of the mind-altering substance I'm anticipating. And let's say the third one is just food coloring and Visine, which causes a dangerous, sometimes life-threatening toxidrome, which has nothing to do with alcohol. It's just like totally, totally different, but it tastes the exact same as the other two. That is often the situation our patients are facing when it comes to the drug that they're trying to use. And I'm not trying to make light of alcohol, but I'm using an analogy with one of the legal familiar drugs to say that our patients don't always have a choice in what they have access to. This gives rise to regional trends in different emerging drugs. And Texas is a bit different than other parts of the country. But another kind of emerging trend is that people are accessing drugs using the dark webs, mail, and other means. And so problems in Philadelphia, problems with drugs in Detroit, problems around the country find their way to Texas. And so as clinicians, it can be really helpful to have some of this on our radar so that if we are seeing things like an overdose that that appears to be an opioid overdose that doesn't totally respond to naloxone, we have a differential of what else could be going on, so we can better serve our patients who are navigating this unpredictable and often poisoned drug supply. So this is from Dr. King's talk, modified a bit to point out when we're thinking about these emerging drugs, they call NPS or novel psychoactive substances, it's helpful to recognize some categories while also acknowledging that these drugs are complicated, not quality controlled, and can have the effects of different sort of categories of drugs we think about, such as psychedelics like psilocybin and LSD, stimulants like amphetamines and cathinones, and then the depressants, which we'll focus on today, particularly benzos and new synthetic opioids. There's also dissociatives, which are in both, and one of the newer ones is different ketamine, so not ketamine itself, but ketamine kind of lookalike drugs. MDMA falls in that kind of in between stimulants and psychedelics. And then a drug that's going to come up during our case today is kratom, which metragenine with many active alkaloids, both with opioid type effects and stimulant type effects. And then cannabinoids, synthetic cannabinoids, which can do anything. And finally, the other drug we'll focus on here during the first 25 minutes or so is alpha-2 agonists. And let's start there. So alpha agonists, one that kind of hit the scene over the last few years and was particularly prominent on the East Coast, but then made its way across the country, was xylazine. So that's the Xylazine, pronounced xylazine. And getting ready for this talk and being at ASAM this year and learning that in many drug markets, actually, xylazine is on the way out, and a newer drug in the same class that acts differently called medetomidine is being found both in community drug checking and then as well as our other ways of knowing about contaminants. So they both fall under the same class of alpha agonists. The way these drugs work is by decreasing the sympathetic outflow and leading to sedation. In the case of xylazine, there were less cardiovascular effects than other common alpha agonists that we're used to in clinical practice. Drugs like clonidine, dexmedetomidine, or Precedex that gets used in ER ICUs, tizanidine, and lofexidine. So these drugs, I think many of us prescribers are familiar with some of their potential cardiovascular effects like bradycardia and hypotension. And xylazine had less of that. The newer one on the block, medetomidine, has more of that cardiovascular effect because it's more highly selective for that receptor, and it's showing up in much higher doses. And so vital sign changes are noted in both overdose and withdrawal. The common adverse effects of these are overdose, withdrawal, and injection-related wounds, which we'll talk more about. And the diagnostic testing, if you think about it just from a pure lab perspective, is a send-out that's not available in most clinical situations. And so again, it gets back to relationships with the people we're serving and just having a real talk about what kind of drugs they've been using and what they know about them. So focusing in on two of the most clinically important effects of these alpha-2s, and this is from one of Claire's recent papers, and focusing on xylazine, continued sedation after naloxone administration was kind of a hallmark for an individual who had been exposed to xylazine. Because it is such a long-acting and heavy sedative, pressure ulcers and skin breakdown are another major issue. And then other medical sequelae that fall from there with blood clots, issues with compartment syndrome, and then nerve, muscle, and soft tissue injury that follows from that. There are things we can do for our patients who are actively using, like checking in and encouraging people to have friends and loved ones nearby, to use naloxone if somebody is exhibiting signs of respiratory depression, to roll people who are nodding over on their side, and to move people often. So the same sort of strategies we use for critically ill patients or patients recovering from critical illness to reduce the risk of pressure wounds, we would also use with people who are exposed to this prolonged heavy sedative. And then the other like really distinct syndrome related to xylazine, which it's not clear whether or not it's as associated with medetomidine, hopefully not, is skin wounds. So these are a large, long, ulcerative wounds that can be deep, and they get better, and they require dedicated teams that can help, address the wound care needs of these patients. Some common complications are bacterial superinfections that require that wound care. And there's other harm reduction strategies to reduce the risk of these wounds. It is most often associated with injection, so exploring other routes of use is a strategy. Rotating sites, giving wounds a rest, or other strategies to reduce the risk of these wounds for people who are actively exposed to xylazine. There are some great resources for TRINC is another word for xylazine, another name for xylazine. So this comes from PennCamp, so the University of Pennsylvania, and it really describes, the QR code is there, describes what folks can do to keep themselves safe and care for the wounds if they do develop wounds. So what to expect in withdrawal. So in the xylazine era, which we're still in certain parts of the country, the withdrawal syndrome was really profound anxiety, dysphoria, and restlessness. So these were patients who had a hard time staying in the hospital or other care setting because of these profound symptoms. With the shift over to medetomidine, teams like at Penn and on the East Coast are noting the cardiovascular withdrawal effects, so severe hypertension and tachycardia, as well as GI issues, so intractable, serious nausea and vomiting that can limit your ability to take oral medications and keep folks hydrated while they suffer through the withdrawal syndrome. And then there's a tremor that comes without clonus, or with a part of this type of with clonus and hyperreactivity. So again, this is from PennCamp, the folks at Penn. Their strategy for managing medetomidine withdrawal starts with aggressive opioid withdrawal management. So long and short-acting opioids, including buprenorphine or methadone, if a patient wishes to manage that opioid component of the withdrawal, because so many folks are coming in exposed to fentanyl and other high-potency synthetic opioids, and have two co-occurring withdrawal syndromes, right? So we want to make sure we're handling as much of the opioid withdrawal as we can, and then utilizing other agents for the alpha agonist withdrawal. So using other alpha agonist withdrawals, which with xylazine, it was sometimes limited by vital signs, how much we could use things like clonidine, tizanidine, dexmedetomidine. And that seems to be less the case with medetomidine. And then as well as drugs like ketamine in the appropriate setting, with aggressive antiemetics, antihypertensive agents, and then adjuncts that we often use for opioid withdrawal. So remember, this case started with a young man with OUD who was brought in by EMS and had a partial response to naloxone. This case continues as this person is admitted for the treatment of ulcerating soft tissue infections with spreading cellulitis and sepsis. They were stabilized in the ER. They report having a heavy habit using the 3 to 4 grams of IV fentanyl daily. And 24 hours after the admission, this person goes into opioid withdrawal, which improved with the first day total daily dose, 60 milligrams of methadone. All right, so the second part of this case is this person gets admitted and treated for a complication with cellulitis with sepsis, is to think about novel opioids. So again, we think about the splintering drug supply. It's not just fentanyls and the other illicit analogs. There's also nitazines and other potent synthetic opioids of somewhat unpredictable potency and duration. So clinical considerations, these are typically high potency, and this can lead to contamination events and overdose spikes, which unfortunately we see fairly often here in Austin. There's an increase in dependence, withdrawal, and pain. And so it's been noted that higher doses of methadone and other opioids to treat withdrawal are required. It's of unpredictable duration, right? So rebound intoxication can happen after naloxone. That wasn't in this case, but in this case, right, this is somebody who's been in the hospital 24 hours and they're having this late fentanyl washout. That is due to fentanyl's lipophilicity. So that means that it is a compound that can move quickly across lipid layers, and that leads to a couple of clinical effects. The first is that rapid overdoses, because it gets into your central nervous system so quickly. It comes out very quickly as well, which can lead to frequent injection. And then, as in this case, with chronic use, fentanyls are stored in the fat and slowly released. So that's a reservoir effect. And patients have the drug has a long variable half-life, and the onset of withdrawal can be quite late, which can complicate buprenorphine starts. And in this case, they were in the hospital for 24 hours before withdrawal hit. And then finally, we're seeing folks using these novel opioids along with stimulants and other adulterants that we're talking about today. One reminder here is to treat the syndrome and not the drug screen. All of the drugs we're talking about today are not picked up on a traditional drug screen. So that kind of the way the slide's set up is sort of gets you to think which of these drugs turns a UDS positive for opiates, even though it still has a high false positive and false negative rate. And that's typically a morphine metabolite, and you get there with heroin or codeine, sometimes hydrocodone and hydromorphone because of metabolism, other times oxycodone because of impurities in the drug manufacture process. But when you're thinking about opioids, right, a standard drug screen looking for opiates is not going to tell you about methadone, fentanyl, buprenorphine, any of these synthetic opioids we're talking about. And so when we're seeing folks with intoxication withdrawal syndromes from novel psychoactive substances, treat that syndrome, talk to the patient, see them at the bedside frequently, and try to figure out what's going on, because the drug screen is typically not helpful in these cases. This is for folks who are interested in offering methadone to folks who are patients who are undergoing withdrawal, particularly from these high-potency synthetics like fentanyls and nitazines. In this case, a patient was able to get started on 60 milligrams methadone day one, which is both illegal and increasingly an emerging practice in the hospital setting for patients with severe opioid withdrawal. All right, and on to the final part of the case. So this 29-year-old with OUD who came in with an overdose and was found to have lower extremity wounds is stabilizing on 90 milligrams of methadone, and on hospital day 4 develops severe anxiety with associated vital sign changes. So a heart rate of 125, blood pressure of 145/92 with normal oxygen sat. And on exam, they're sweaty, they're anxious, and they have this fine high frequency tremor. So what could this be? I'm just going to pause for a second there. The drugs that we've talked about already, for somebody who's stabilized, they're in a reasonable dose of methadone, their opioid withdrawal is treated. When they first came in, right, they were altered, and maybe that was the sepsis, why they weren't responding to naloxone. Maybe it was alpha-2 agonists, but now we're 4 days out. So just pause, give folks a second to consider. This is my approach. I'm kind of sitting with this question as my differential for MOUD starts gone wrong. So one is just undertreated opioid withdrawal. The second, when we're using buprenorphine, is butte-precipitated withdrawal, and that's typically sudden and severe. Patients are, we're talking about today about novel psychoactive substances, right? And so often it's one explanation that can explain a number of different clinical findings. But on the other side, there's this kind of rule in clinical reasoning, Hickham's dictum, which states that patients can have as many problems as they damn well please. And we can't always be as parsimonious, because patients often come in with things like sepsis, as we saw in this case. And then other substance withdrawal, which we'll talk about now. And in the case of somebody who's going to withdraw 4 days in, benzos are highly likely. The withdrawal from benzos is similar to, but distinct from alcohol in its time course. So this shows up later and is frankly less predictable for novel benzos that our patients are often exposed to on the street. And the other difference is delirium often comes first. So in alcohol withdrawal, if you're going to see delirium that's part of that complicated withdrawal syndrome, it follows the kind of like predictable course. And in benzos, it can be the other way. There's limited evidence base for treatment. There's a recent ASAM guideline that came out that tried to build some clinical tools. I encourage people to check it out based on that limited evidence base. that includes behavioral approaches, treating co-occurring disorders. From the medical management and withdrawal perspective, we're also often using benzos and barbiturates along with adjuncts. And then it's not safe to just get people off of benzos. You need to let their nervous system adjust. And so there's kind of different durations of benzos, and with a strong preference for prolonged or Ashton method. So this is the Professor Heather Ashton's guide that can be really helpful when you're working with patients over the long term on a benzo taper. So in the acute the final point here is about managing this in the acute setting. So when a patient is seemingly stabilizing from whatever brings them to the hospital, and if the term drug seeking starts to get thrown around, it's a great time for kind of like a big pause, because that word drug seeking gets you all the stigma of a drug problem, but none of the like really thorough clinical reasoning or the treatments that we know work. So if that word gets thrown out, start thinking, okay, what could be going on here? Is this substance use disorder, somebody having cravings, and we can address that? Is this withdrawal from a different class that we're not addressing? Is this person in pain, distress? Is there a sleep problem? Is this active PTSD? Or is it often, I think what people are sort of insinuating when we talk about drug seeking, is somebody trying to divert or misuse their medications? And I put it last in the differential because when people are coming in for help, that does not happen very often. And if we just name it, then we can really assess how much do we think that's going on, or could it be something else like an unexpected benzo withdrawal syndrome. This is the expected timeline of alcohol withdrawal. And I'll just draw your attention to the x-axis there. So, it's like all the actions early on. So you kind of know what's going on in the first 2 or 3 days, and often much, much earlier when it comes to alcohol withdrawal. Whereas with benzo withdrawal, check out that x-axis, right? So we're talking about days in before things really take off in some cases. And benzo withdrawal can also have a very prolonged course. And again, that's why we recommend, it's generally recommended, including the new ASAM guidance, to do a prolonged taper with folks. The many patients in Texas historically, as I'm currently, have had access to high dose and duration benzodiazepine prescriptions. Those have gone down for the state of Texas, and often our patients are accessing black market or drugs, or sometimes called study drugs. And these are, again, benzos that are not used in clinical practice, and they can be both highly potent and very long acting. So drugs like Xylazine, brome, alprazolam, that have, and again, another shout out to Claire's talk. If you ever want to try to heal from your OCHEM trauma, listen to a Claire talk, because she'll explain how the different side chains can affect the pharmacokinetics and pharmacodynamics of these drugs. But they can be highly potent and really long acting. And so if our patients are exposed to these, we need to kind of keep our index of suspicion up. These are, for time's sake, everybody will get these slides. This is from the Harm Reduction Action Center, talking about benzo harm reduction, because even if our patients aren't in a place where they want to talk about what a taper could look like, there's still so much we can do to engage them and help keep them safe. I'm going to end with the epi. So this is from a paper in 2022 that kind of drives on the point that drug crises are local. This figure shows the percentage of fentanyl overdose deaths that have meth, heroines, or misspell there, or benzodiazepines. And if you look at methamphetamine there, right, like, so 30 to 35% of people who are identified as having died of a fentanyl overdose also had methamphetamine identified on postmortem toxicology. And we see that clinically, right? That's common. I think what surprised me in this paper was all the way on the right there, the image of where Texas really stands out along, I think that's Utah, of how the frequency with which benzodiazepines are identified in postmortem toxicology. So benzos show up a whole lot in clinical practice. I think I've missed it a lot on the front end as we've met people, particularly with OUD, who are looking to stabilize in the outpatient setting on buprenorphine, and kind of the withdrawal shows up later. Again, this is postmortem data from the same paper looking at Texas as the top row there. These are the most common drugs that are co-involved with fentanyl deaths over time. And then the benzos is kind of the sky blue there. So for years, benzos, along with prescription opioids, although less so more recently, are found in these overdose deaths. And then with the most recent year in their data set, methamphetamine was slightly more commonly found. So benzos are very, very common. And I kind of ended with that with the clinical case to really, and then brought the epi up to bring this. This is what we're going to see more often in practice, likely than the other two at this time. The drug crises are local. We are still living in a country with an unacceptable rate of death, and we're losing too many of our friends. And hopefully by identifying and helping mitigate the harms related to these substances, we can help continue to for this curve to go down. We don't know why opioid overdoses are going down. Great news out of the CDC in the last month here that overdose rates nationally are probably down about a quarter from last year. But we have a long way to go, and hopefully understanding a bit about novel psychoactive substances can help continue to bend that down, because so many of us know someone who's died from an overdose, and we know these are preventable. It doesn't need to be this way. All right, and then I've gone a bit over, but I'm going to say some quick stuff about kratom because our last case is about kratom. So for folks who have not heard about it, this is a natural product that's available on the internet and smoke shops. It's from Southeast Asia, and botanical kratom is different to what we're going to see clinically, because in the United States, like pretty much everything else, we find a way for things to be more potent, more big, and that's true for kratom. So the capsules and teas and other stuff people are getting from shops have very high levels of the active alkaloids in kratom. At a low dose, kratom is a stimulant, and at a higher dose, it's a partial mu opioid receptor agonist. In surveys, patients have reported using it for the self-treatment of chronic pain, anxiety, depression, and withdrawal. On its own, it has a low risk of life-threatening intoxication. It's really unclear if there's ever been a definitive single monodrug overdose from kratom alone. It does carry a risk of physical dependence withdrawal and substance use disorder, and there is limited treatment experience for kratom use disorder, kratom addiction, which we'll talk more about in our case. And I'll stop there.
Thank you, Dr. Weems. Oh, sorry, go ahead. Were you going to say something?
Do we have any time for questions, or should we bounce
Yes,
over?
we have time for a question or two before we move on to announcements, but I will say that was the perfect segue into our case. But yes, the floor is open for any questions for Dr. Weems.
I'm noticing in the chat, Carlos Dostal and Bobby Sessions of Central Texas, Coastal Connection, both pointed out alcohol withdrawal. We're talking about what could be going on with this case. I love that. Yishao is asking, how long does xylazine stay in the body so you can test for it? I don't know. I used to know. This is discoverable, but I don't know. Does anybody else know off the top? I can look it up during the announcements. One of the challenges, it's an LCMS, GCMS send out, and the prevalence studies that were done in the Philly ERs, it was from the ER. So as soon as people hit the acute care setting, those were the urine samples they were sending off. It's the same strategy they're using to identify medetomidine. And so I didn't read that in the paper I reviewed for this talk. So I don't know, man, but I'll check it out, Yishao. It's a great question.
Dr. DeMoss, I do see you're in. Oh, go ahead. Yes.
Yeah, no, I have one question. My guess, John, is probably 3 to 5 days for the xylazine in your system, but that's kind of average for everybody. But then my question for you, John, is in patients with alpha-2 agonist withdrawal, I think I posed this question for the overdose piece. Would alpha-2 antagonist medications such as mirtazapine, brand name Remeron, I don't think I've seen any studies that looked at deployment of that for helping in overdose scenarios. But the question for you specifically is, would you, I guess theoretically, would anticipate worsening withdrawal with the administration of mirtazapine, other alpha-2 antagonists in people who are already withdrawing from alpha-2 agonists.
I think too, the other receptor effects would be tough with that too, right? Because you're hoping to, you know what I mean? You wake them up, but then the histaminergic stuff, so I think mirtazapine, it's a great question. I should have said it front. I don't know, but I can ask around. I'll ask Claire and some of the East Coast folks. The standard practice is great supportive care, right? So often, if folks are working in detox centers or residentials, I think it's worth exploring what strategies are available for airway, establishing an airway like an LMA. Intubation it comes with significant risks of harms. And so if we can avoid that by keeping people well oxygenated, positioning, and potentially airway support, that can be really helpful. And then just, I think it often gets overlooked to just being with somebody, rubbing on that it's going to be all right, we're going to be here. Making myself say that because I don't know the answer to mirtazapine. That's super interesting, man. I don't know.
No worries. No worries.
Find out.
Yeah,
And Lindsay, I do see your hand is raised. If you could ask your question, please.
Yeah. Do you think, or how do you feel that the like making some substances like benzo less prescribed and like painkillers less prescribed creates some of these alternate substances that we see that we don't know how they react in the body and makes it more dangerous for the drug supply?
I think that pattern, right? The iron law of prohibition leading to riskier and riskier experiences for people using drugs, just so well established with particularly opioids, right? The waves of the epidemic are so closely tied to that. And I think I look at when I could just speak as a clinician, right? I don't see patients with kratom use who've had in their life for a long time who were able to access comprehensive pain care, for instance, or were able to keep on a pain regimen that worked for them that didn't have notable adverse effects. And I think a lot of the kind of pendulum swinging away from opioids and a lot of the way the 2016 CDC guidelines were interpreted and turned into policy got us in a situation where, particularly with kratom, people living with function limiting pain have few other options, unfortunately. And so just as a clinician, I see that in my folks who have that. One way of thinking about this is, again, it's come from harm reduction orgs, community drug checking, and some qualitative papers that have been written about the alpha-2 agonists is, in a lot of communities, heroin's hard to find. Fentanyl's fast on, fast off. And Xylazine has legs. It's just around for a much longer period of time. And so if you think of, and a lot of people having that experience of rapid on, rapid off with fentanyl, that's somewhat mitigated by a sedative that's longer acting. So again, and I hope that speaks to your question a little bit of like, that's people, yeah, when they don't have choices, right? That's like the poison alcohol analogy. When people don't have choices, we see a lot of unneeded suffering.
Thank you, Dr. Weems, and thank you all for your questions and your comments in the chat. In the interest of time, we will move on to announcements, but should you have any other questions, please put them in the chat, and Dr. Weems, I'll point your attention to there in case someone does ask something. Karen, whenever you have a moment, if you can pull up those slides, please. Thank you so much. So to claim your CME credits for today's session, please ensure that you do have a registered account and then text attend 100-98739 to 844-502-1338 no later than midnight tonight. Next slide, please. And do you have a difficult case that you or your team have encountered? If so, CSTAT does offer you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation as we do provide you with the forms to fill out and assist you with your case presentation. We'll see Ms. Maddie Escamilla do this here shortly. If you are interested in presenting a case, please email us at the email that Karen will be sharing in the chat. Next slide, please. Thank you, Karen. Join us for our Maternal Health Echo program. The next session will be on Tuesday, June 3rd at 12 p.m. Central Time. This program equips prenatal healthcare providers with the necessary training, consultation, and support to enhance care delivery for pregnant and postpartum women experiencing substance use disorder. Please register using the link in the chat. Thank you. And we're pleased to welcome Andy from Naloxone, Texas, who will be sharing a brief update on some exciting initiatives they're bringing to our community of learners. The floor is yours, Andy.
Oh, hi everyone. Can you hear me?
Yes, we can hear
Okay,
you.
perfect. So as she's mentioned, I do have some exciting announcements for Naloxone, Texas. So on the side, we have the information here that is really great for just what our program is doing. I know that there have been some calls, especially with the current legislative landscape, that people were kind of worried about our program, but we wanted to make sure that you guys knew it was going strong. And we also wanted to also like invite you guys to sign up to become a hub. Sorry, not a hub, sorry. It is a local vending machine location. So being a vending machine location would entail having a vending machine available, and I believe somebody will drop the link in the chat or I can do it after I finish speaking. And so that person, if you choose to become a place for our vending machines, we just would ask that you monitor it and just let us know if it needs to be stocked so that we can kind of get that resource out into the community. We're really looking for community partners to have these local vending machines at, just because we understand that organizations and everything can't always get to everyone, especially when in a crisis or when an overdose is actively happening. And so being able to get these into the community is something that we're super excited about. And we really look forward to working with you all. Like I said, I'll post the link in the chat. If you have any questions, please email us at naloxonetexas@uthcsa.edu, and we can get those answered for you.
Wonderful. Thanks so much, Andy.
Hooray.
Next slide, please. Awesome. So the Center for Substance Use Training and Telementoring by Be Well, Texas is still accepting applications for our mood mentoring program. Join us for an exclusive opportunity for prescribers to receive personalized one-on-one mentorship on how to integrate mood services into daily clinical practice. And this exclusive offer is available to a select few in the Texas Public Health District 8. So don't miss this wonderful opportunity. And if you're interested in taking advantage of this opportunity, please visit the link that Karen will be sharing in the chat. Next slide, please. Thank you. And finally, please do join us for our next session on June 12th for a session on methamphetamines. And this is part of our 4-part series on common substances. Thank you so much. So before we do move on to the case today, I'd like to remind everyone that no protected health information is allowed in either the chat or our discussion. And let's continue making the space inclusive and open to respectful dialogue. So with that, Maddie, once Karen shares the case, please walk us through it. Thank you.
Hi there. Thank you. Can everybody hear me okay? I took my headphones off. Okay, perfect.
Yes.
All right. So this is a 32-year-old male that we saw about a year ago. So it's been a little while, but he presented initially to the ER for right facial pain and swelling. He was evaluated, found to have facial cellulitis, and admitted to our hospitalist service. Sorry, I'm going to go ahead and say our questions now, and I know we'll come back to them at the end. But the questions that we want to ask about this case, and I think that Dr. Weems kind of helped us answer earlier during his presentation as well. How would one manage kratom intoxication? How would we manage kratom withdrawal? And is there any evidence on long-term outcomes for the use of buprenorphine in kratom use disorder? So again, our patient was admitted to our hospitalist service, started on IV antibiotics, And the psychiatry consult service was asked to come on his case due to some concern for opioid withdrawal symptoms. So the patient reported a history of nicotine and cannabis use disorder. He continued to use daily. And he also reported that he had a long-term history of fentanyl use disorder. He had used fentanyl for about 5 years, possibly longer. And he had recently stopped, maybe a month or two prior to his presentation, because he was trying to get off fentanyl by using kratom. So he reported that he had started to use kratom daily. He couldn't really quantify his use, but he reported that he had been smoking it and buying it off random shops, smoke shops around the city. But that his primary intention for using was to get off the fentanyl. He also had a history of anxiety, had been previously prescribed psychotropic medications for anxiety, and he did feel that the kratom would alleviate his anxiety symptoms as well. So his primary substance use diagnoses: opioid use disorder, cannabis use disorder, tobacco use disorder, but also some remote history of benzodiazepine misuse. He had some experience using Suboxone in the past throughout the 5 years or so that he had been using fentanyl. He was vague about why this, is not something he continued to use, or why he didn't. He found it beneficial, but he had stopped for various reasons throughout the year. He had never sought inpatient substance use treatment, but had been, managed outpatient, had some counseling as well. No current support groups, and no current treatment. So when we first evaluated the patient, we determined that he was experiencing some opioid withdrawal symptoms similar to opioid withdrawal. His COWS at the time was 9, but he reported that he was not interested in restarting buprenorphine, that he wanted to continue to use kratom once he discharged, but that in the meantime, he wanted his pain managed with full agonist opioids. So we continued to see him. In case he changed his mind, we offered referrals to our Bridge clinic. And the following day, he had been started on Oxy, I think 5Q6 for severe pain. And the following day, he told us that, it was not really helping him, and that he was actually wanting to start buprenorphine instead. So we started with, I guess, a relatively low dose, 4 milligrams, just per the standard induction, even though he was not using fentanyl. And it did improve his symptoms. We actually felt kind of surprised that with kratom, the patient seemed to need less buprenorphine to alleviate their withdrawal symptoms than with fentanyl or heroin. So he was only admitted for about 2 days, and he got up to a total of 6 milligrams of Suboxone or buprenorphine, and reported that he felt comfortable with that dose, did not want to increase it further, and would continue outpatient. He was supposed to follow up with our Bridge clinic, but he actually did not go back, and we didn't see him again for about 5 months when he came back to the ER for another wound, and was at the time using fentanyl again. Sorry, his social history: he was at the time supposedly living with his parents, had children, but no real contact with them, was not employed. He had been diagnosed with anxiety in the past, and was also he resumed management with Remeron, actually, which Dr. DeMoss mentioned earlier, while he was admitted, but he also did not follow up with our outpatient behavioral health services. His cellulitis was treated. He completed treatment. He did not leave. He stayed throughout, the 2 to 3 days that he was supposed to be in the hospital, and left with a prescription for his Suboxone and a referral to outpatient substance use treatment. We also provided Narcan, given his history. So back to our questions, how would we manage kratom intoxication, kratom withdrawal, and is there any evidence on long-term outcomes for the use of bup and kratom use disorder?
Excellent. Thank you so much, Maddie. And the floor is open for discussion. Are there any questions or comments from anyone on the call today?
Well, excellent, excellent didactic by Dr. Weems, and excellent case that matches up perfectly by Maddie. It's good to see you, Maddie.
Right.
So, with a couple of the things that you noted, managing the kratom on a slightly lower dose of the buprenorphine, I have witnessed that as well, right? Especially with my folks who um, have been using it in a similar capacity to what you presented, right? Like, I feel like I see three pots of patients that use kratom. The ones who went that route because they felt, oh, it's a plant, it's natural. I don't want to take serious pain management medications. I'm going to take the natural route. And unfortunately, it is advertised as a natural cure-all on lots of billboards all over the place. So there is a lot of misconception out there. And I've had a few patients come in that have never used opioids before, but they started with kratom and now they're having issues. And then folks like you presented where they had an opiate use disorder and using like some harm reduction strategies. Okay, instead of using this fentanyl, I'm going to go to this more natural route with kratom. Those two pots of people I feel like do really well on buprenorphine and may not need it as long or at higher doses that I would with like my fentanyl users or my heroin users. But I recently have a new pot and they are using it's kind of a newer substance. It's called 7-OH and it is one of the 47 alkaloids that are in kratom and it's one specific alkaloid that they have distilled out. Because, like what Dr. Weems was saying, yeah, it's advertised as a botanical, as a plant, but you're not getting like the leaf. You're getting it distilled down to make it as strong and as potent as possible. And they have started distilling out this one specific one. I do have a question though, because you had mentioned that he had a history of anxiety. How did your treatment and the medications you used for anxiety work in combination with the kratom? Because that is something that I struggle with the especially the 7-OH folks, is that their anxiety can be difficult to manage. How did you guys manage that with your patient?
I think, unfortunately, he was only here a couple days. And so the Remeron was restarted, but he had been in and out of treatment. And I think that since he had started using kratom, he had not been managed with psychotropics for his anxiety. But he reported that the kratom helped with his anxiety. So, his plan all along was to, upon discharge, return to using kratom because it was working. He did note that the difficult part for him was that he couldn't quite find the right dose. He felt that if he used too much, he would experience abdominal pain and constipation. If he used too little, he would start feeling withdrawal symptoms. So that was kind of hard. But in regard to his anxiety, we restarted treatment, hoping that he would continue to follow up. But I wouldn't. I guess I don't know how the Remeron really helped in the management of his anxiety with concurrent kratom use after he left.
Yeah, I do see that a lot. And how I present it or have in the past to my patients, right? A lot of patients also report that alcohol helps with their anxiety. But in the long term, it ends up shifting that homeostasis and upregulating those receptors so that when they're without it, their anxiety is worse than it ever was before they started. So it's escalating the problem, not necessarily treating it. And so trying to explain that. When you guys talked to him about the buprenorphine, with the feedback that he gave you about not being able to find the right dose of kratom, right? Like, well, that is a problem of buying things that are completely unregulated, is you have no idea what the dose is going to be in each of those pills. Did that come up at all in your discussions with comparing the pros and cons of remaining on the kratom or going back to the bupe?
Yeah, I think we did spend a significant amount of time educating him about what we know about kratom and how it is difficult to make any kind of safe recommendations about something that's not regulated. I think that, you know, his previous experience with Suboxone, and, you know, again, I don't really know the depths of why it hadn't worked for him or why he had fallen off treatment. I think he just kind of felt like at this time he could kind of play with the kratom and find what worked for him, and was not really interested in going back to something else. But we did try to educate, we did educate about why Suboxone could still be a better treatment for him, and at the very least we could do it safely. Sorry, I was reading Dr. Chan's comment on the chat.
Yes, if you can unmute and expand on that real quick.
Yes, can you hear me?
Yes, I can hear you. Thank you.
Yeah, no, that was a great case. I'm never used to thinking about herbal supplements as like a reason for drug withdrawals, but now with kind of kratom use and it being kind of marketed as, oh, this is very natural, this is just herbal remedies, but it's still behaving like an opioid. Definitely something I need to start thinking about asking in my patients who I'm managing for withdrawal symptoms.
Thank you, Dr. Chen. And I do see that Carlos Dostal wrote, I'm just learning about it here. I'm sure it's been down in Galveston County too. Just hasn't been on my radar. And I know that Dr. Kowalczyk had mentioned where she is located. And forgive me, I don't remember where you are right now, but there has been some kind of geographical trends going on. If you could expand on that, Dr. Kowalczyk, please, or share with the group what you had shared in the pre-session.
Yeah, sure. So I do see it in the patients I admitted Santa Maria for opiate use disorder. Sometimes they report using kratom as well. I've only had one or two cases over the years, and probably within the last 5 years or so, where someone has presented that is just using kratom at the time. Usually, they've transitioned from full opioid to kratom at some point in the past. And a lot of my patients that are using kratom along with their opiates, it's usually when they are having episodes where they're wanting to self-treat or to bridge a gap that they're experiencing in access to their opiate of choice. And I find that buprenorphine works well for most, but yeah, I don't see it as often here as I think it may be being seen centrally. Um, in the one or two cases I can recall over the last 5 years, folks just doing kratom have come from Central Texas. So it does. I wonder if anybody else in Houston is seeing it more often than I am.
Thank you, Dr. Kowalczyk. And so given the time, I would like to pass the mic over to Dr. Weems just to give us a summary of recommendations for Maddie and for anyone here on the call. Go ahead, Dr. Weems, the floor is yours.
Really, thanks everybody for joining today to the hub and Maddie for the great case. I think the first take home is staying engaged. In the case of this young man who came in with kratom withdrawal, declined buprenorphine initially, inappropriately was treated with full agonists for the presenting pain syndrome. The team kept coming back and offering things and keeping that menu of options available to our folks with substance use disorder, and the kinds of support that fit for them can help improve retention and meet our folks where they're at. The second one is to get real on risks. And for this individual, it seemed like at the time of the first hospitalization, kratom was reducing his risks, right? 5 years of IV fentanyl versus kratom. One of the leading drivers of premature mortality in the United States versus a botanical that it's complicated because we don't know what's in it. We can't guide our patients with certainty, but we can counsel in the setting of uncertainty about what safety can look like. that for that individual, the risks weren't so great with kratom, and unfortunately, when they presented back, the risks of their drug use at that time were substantially more. And for patients with kratom use disorder, particularly those with co-occurring opioid use disorder, offering MOUD is the standard of care and can help reduce those risks substantially. The third take home is, if it's not on your radar, it's not on your differential, you can't find what you're not looking for. And so when we're helping folks who use drugs, we need to do our best to keep our finger on the pulse of what the emerging drugs are. In Texas, novel benzos are very common. We talked a lot about kratom today, which is also common. The alpha-2 agonists I anticipate to be more, they're everywhere else, so they're going to be here more often sooner. eShop's looking for them up in North Texas. And then finally, unfortunately, novel synthetic opioids continue to be common. So thanks everybody for the case and the discussion today.
Excellent. Thanks, Dr. Weems. And thank you to everyone that has attended today's session. I guess, again, a special thank you to Maddie and to Dr. Weems for presenting today. As a reminder, to claim your CME credit, you must text by midnight tonight. Text to 10-100-98739 to the number that Karen shared here in the last message in the chat. And we also kindly ask that you complete the post-session feedback survey using the link in the chat as well. We look forward to seeing everyone at our next ECHO in June. Thank you so much. Have a great rest of your week.